Hello, everybody. My name is Dr. Radha Krishna. Uh, this is a half an hour program for doctors who are attending this online discussion. Okay, the topic today is frozen shoulder, which is very commonly seen in our medical practice. And here I'm going to discuss step-by-step guidance of how to manage frozen shoulder. Uh, Again, my name is Dr. Radha Krishna, and one of my qualification is molecular medicine. Okay. Uh, okay. Okay. The first step is what's happening? Is let's imagine that the patient is sitting in front of us. That's the most important picture that we have to draw the mind. Okay. And the patient sitting in the front of us. What is the first step that you and I want to do? Step one. Okay. How I look at patients is this the way. First step is a patient sitting in the front, and we need to take a very detailed history. This is a common missing point of most of us where we misdiagnosis and we never take a detailed history. So the most important thing to take a detailed history. What is the history that we want to take? Okay, and the patient is sitting in the front of us, and we ask for the presenting uh, complaints. So it can be a pain. So you can ask when does it happen pain, and usually frozen shoulder, they find it very difficult to sleep in the night, especially their favorite position maybe on the right side or the left side, and they can't turn and sleep that particular side. And not only pain, there will be reduced movement. There will be uh, uh, the reduced movement, range of movement is also reduced, and the stiffness. So they are unable to sleep the whole night. They toss and turn to get a favorite position. So very important to ask which side of the shoulder is painful, on the right side or the left side. Okay, very, very important. Okay, these are the things that we need to be important because the quality of their sleep, the quality of the mattress or the quality of the pillow, they keep arranging them the whole time. Okay, second is to find out what is the pain score. Different people have different range of pain score. It can range from 2 to 10. Okay, and depends on the injury or the location of the pain. For some, even little bit of pain, they can be classified as 10. Some those who are so used to the pain, the 10 can be looking like a 2 or a 3. Okay, very important. Okay, and then we can ask the onset of the symptoms. Ask them, when did it start? Okay, when or during a workout or a fall or they accidentally carried something, and then this whole thing started. And then we have to ask the duration of pain. Okay, symptoms, duration of the symptoms. Sometimes the pain can be the whole day. So sometimes it's debilitating, or sometimes at a certain position they get a pain. It's very important because I will explain to you the management component of this. Okay, then we have to have a very clear medical history. Was there a surgery before on the particular surgery or shoulder? Was there any injuries? And then we have to ask systemic diseases like diabetes. Are you a diabetic? Or if you are a diabetic, what medications are you on? Whether it's taking insulin injection or tablets, whether there's a person is having a hypothyroid or a hyperthyroid, and then we ask to ask the list of medications the patient is on, or the person is having rheumatoid arthritis, okay, and ask what medication the patient is on, when did it start, the duration, and what are the other joints involved. And then we also need to check out whether the person is having cardiovascular diseases. Maybe he has got an IHT problem, okay, maybe it's a undiagnosed IHT. Okay? Then we also can later do a ECG and many other parameters to find out. Then we have to also ask very careful history of previous medical history, any musculoskeletal disorders, okay, and inflammatory conditions or neurological disorders. These are some of the points that we generally miss because we are so focused on the pain that we tend to overlook the systemic diseases problems. Okay. Then in the medicine history, what is the current medication the patient is on? Ask for the list of medication. They may be straight away taking Acoxia, or some of them may start with Panadol, paracetamol, and then they go off to ibuprofen. Maybe some of them on tramadol. So we'll never know. Some of them may be gabapentin or many other medications the patient is on. Okay, maybe they may be on some nutraceutical supplements like curcumin, or they may be an omega. So we have to ask, and we also have to ask a history of any anticoagulants, which is very important because there can be some interactions. And then, is it the first time they had it, or they had a previous history of treatment? And it's very, very important that sometimes it reoccurs in the same place. They will tell you, doctor, I had this injury before, it has come back. So that's a very, very important clue. I'll show you towards the end of the discussion. Okay, and then functional impact. Ask them the daily activity. What is the daily activity, and whether they walk, they carry, or their handbag, or something on the strap of the right arm or left arm. And then you ask for the hobbies and the work. Maybe they come and do gardening, and they are digging some of their gardening process, and they injure themselves. We have to ask all these details. Their social life, okay, social, occupational, lifestyle. Okay, some of them may be playing badminton, or they may be playing tennis, or some of them are swimmers. So we take a careful history of their social history. Then associated symptoms. Is it the only shoulder, or is they having a knee pain or associated knee pain, or are they having um, um, any neurological symptoms, or are they having fleeting joint pains? Is very important because that gives us a clue of the underlying causative factors. So the most important latest list of questions currently we need to understand that we have to ask history of COVID infections. Okay, and COVIDs are associated with spike protein, and that can trigger a series of autoimmune conditions in the body, and they may result in all these joint pains, and one of them will be frozen shoulder. Then we also need to ask vaccine injuries. Vaccine injuries is another challenge of having tendonitis. Okay, then we have to ask history of whether they had amalgam, and some of them older people, they will tell you there's no more amalgam, doctor, it has fall off, but still there's mercury in the body, it has not been eliminated. Okay, these are some of the additional questions we need to be aware at the current settings. Okay, what is step two? Step two, again, the patient is sitting in front of us. What are we going to do after history taking? Step two is to check the range of the movement. Okay, examine the patient very carefully. Find out the point of pain, the spot that is most painful. Check range movement. Is it just 10 degrees? Is it so badly frozen? Or they can lift up the arm into a 30-degree position, abduct it. Okay, they adduct it, or they can cross across the other arm. Check the range, and usually they cannot put their arm behind their back, and they cannot, and they find it very difficult to, like women, unbutton. Okay, and they find there's very limited back movement, and we need to find the range so that in the subsequent treatment we can see the range of improvement, or during the follow-up. Okay, what will be step three? Step three will be, from there we can do an investigation. The basic investigation we can ask is an X-ray. That's the most basic thing. Or we can ask for ultrasound. Or sometimes the injury is so bad that we may require MRI. And we can also do some laboratory investigations, whether it's inflammatory markers. If it's very, very bad, okay, maybe some orthopedic surgeon may suggest arthrography, okay, to see the details inside rather than very gross outside picture. Okay, what is step four? Step four, after going through the history, going through the range of movements, the investigations, and then we come to step four will be, what is the stages of a frozen shoulder? Is it stage one, stage two, stage three, stage four? Is extremely important. During the inflammatory stage, which is very early between the first 3 months, it's very, very, very painful. And then slowly, because of the limiting of the range of movement of the arm. It'll be a freezing moment stage where there is less pain, but there's still restricted pain, restrictive movement of the arm, and it's still painful. Stage 3 is where it's totally frozen. Okay, frozen is until they cannot lift up their arm, and there's very limited movement. And if we were to encourage exercises, physiotherapy, and it goes into what you call a thawing state, that can range between 15 months to 24 months. Can you, if you look very carefully, this is almost like 2 years of his person's life is gone. And those who have really got frozen shoulder will understand the difficulty they have in their sleep and loss of sleep. The whole night they will not be able to sleep well. Okay. Step 5. So now we stage the disease or stage the frozen shoulder. What is step 5? Step 5 is the management. So management is important based on your history. Okay. Very important. So as a patient sitting in the front of us, now this is how I look at things. We are look at the local issues and a systemic issues. Okay, this is the point of difference between me and whoever who are not able to manage frozen shoulder. Okay, so step 1 in this is whether you classify as the patient is talking. We ask, is it mild, moderate, or severe? Mild, moderate, or severe. So it has to be, as he's talking, we ask the pain score, is it mild, moderate, or severe? That will determine the management of our drugs or injection or invasive or non-invasive. So next question, is it urgent or important? Some of them will be so bad, it'll become urgent. So the point of this pointer will be how we manage. Sometimes the patient may be having 3 months, 4 months, so it may not be urgent. It's just important. Next, after we have classified the mild, moderate, severe, is it urgent or important? Now we take the next step and to find out what is the cause. Okay, now again, we come back to the step. Okay, the patient is sitting in front of us. Now we are looking for a cause. How do we look for a cause? Look at the local issues of the shoulder. Okay, local. Gender, usually above 50 will be more woman. Okay, it can be male or woman or man. Okay, gender, and older age will have more likely to have diseases related frozen shoulder. Younger age maybe is a tendonitis, or they had a fall or rotator cuff tear, or a few fibers have torn. There may be bursitis. There may be a previous history of surgery. So we are very careful. So as we are observing the patient will tell you very specifically and point out where exactly is related to. So you have to look at the age group, the gender, the immobility, the trauma, previous surgery, inflammation, fibrosis, rotator cuff muscle tear, and bursitis. Okay. So now from the local, we go a little bit deeper. Okay. Step 7. So what I found is they can be associated with mineral deficiencies like calcium deficiency, magnesium deficiency, D3 deficiency, B12 deficiency, especially in diabetes, because of oxidative stress or many other ages pathway. There can be inflammatory going on. Okay, so second step is from the outside, like you said, whether it's a acroclavicular joint disruption or a muscle tear or bursitis. Next is the minerals, and I find this is one of the most important factors where a lot of doctors miss this particular point. Next, we go down a little bit further. Okay, is it a local malignancy we are looking at? Sometimes this is one of the important factors we miss. It's a pathology somewhere with the secondaries at the local, and we might miss some secondaries down there. That's a third point we have to be very careful about and look at the age groups. Okay, step 9. Step 9, now from the shoulder, you look at the neck. Is there a neck problem like cervical radiculopathy, cervical spondylosis, okay, cervical facet joint dysfunction? Look at cervical disc herniation, whether it's neck sprain. So when they wake up early morning, they had a sprain in the neck. Accidentally, they lifted a bucket or they tried to get out from the bed, and then they sprained the neck, and then it is causing a referral pain on the shoulder. And then over the period, it becomes a little bit associated with the neck and is classified as frozen shoulder. So it's very important to examine the neck, and then you go over the cervical spine and feel up, feel over the both mastoids. You can trace down the pain to the shoulder. The next thing, after the neck, the back of the neck, now you come to the front. Okay, we come to the front. It can be associated with Hashimoto's. Okay, joint manifestation of thyroid disorders. Okay, decreased metabolic rate and tissue disturbances, and there can be autoimmune thyroid diseases is associated with frozen shoulder. So most of us will tend to be so focused on the shoulder that we forgot about the systemic diseases. Okay, step 11 will be GERDs. So sometimes the GERDs can be associated with frozen shoulder, especially when it comes to very high up or the esophagitis, and that can trigger spasm, and then it may result in frozen shoulder. So coming back again from the local shoulder issues like acroclavicular joint or a muscle tendon tear, and then local, we went down to the next step is for the minerals. Then we talked about maybe they can be secondaries. From there, we went to the back of the neck to examine, and then we went to Hashimoto's to the front. Then we went down to GERDs. From there, we go down one more step at the gallbladder. Okay, gallbladder can also give rise to frozen shoulder-like symptoms. So don't forget to palpate or ask history of indigestion, bloating abdomen, or pain during the consuming of high-fat diet. So that is another point that generally we miss. So we may end up giving NSAID, which may not be solving their problem. Okay. The next step, if it's on the left side, then you ask history of heart attack or angina, maybe related to the neck, and we may misdiagnose this as frozen shoulder. It's important at this point, especially more towards the 30 years and above, and it's a very careful history, ask history of hypertension, IHT, or exertional pain, right? Then the next step after this is autoimmune disorders. Commonly, systemic autoimmune disorders may not only involve a frozen shoulder, may be involving multiple other joints all over the body. Okay. In a quick summary, immobilization is important, as history of trauma and injury, systemic diseases like hypertension, diabetes, thyroid, age and the gender, autoimmune, mineral deficiency, and tumors and secondaries. Okay, what will be the next step? Okay, the next step management will be very simple. Is NSAID, physiotherapy, steroid injection, PEMF, TENS, and many others, which I'll go one step after another now. Okay, medical management. Step 1 will be the medical management. So medical management is involving physiotherapy. Okay, try to increase the range of movement. As we increase the range of movement, it'll be less painful. Okay, this is the one thing that you and I have to learn to practice in our clinical setup. We are straight not going into the drugs. Okay, so the second step will be giving drugs. So it can be anywhere from brufen to Ponstan, mefenamic acid uh, to arcoxia or a drug of your choice, which you are quite comfortable. Question: How long do we give? These drugs? How long? So we need to have an exit strategy. Is it 1 week? Is it twice a day? Is it three weeks? And all these drugs comes with associated with side effects like gastritis, peptic ulcer. Okay, many other problems associated. Sometimes the patient will be self-medicating themselves, so they may end up with a renal profile changes. Okay, it's very important. Then even CBD can be given. Okay, CBD is not available in Malaysia, but in many other places they are using CBD to relieve pain and inflammation. The next step is I use RK0. I'll tell you what is so special about this. Okay, I use on the spot. I generally give 2 capsules of RK0, and the pain is relieved almost immediately. I give you an example. Okay, here's a video I want to play for you. So all it took is 5 minutes when we gave RK0 on the spot, 5 minutes, and he's smiling away. Can you see? He said he has no burden lifting up. So this is what I do. As I'm talking to the patient, I'll generally give 2 capsules of RK0, and when I finish examining, talking to him, suddenly he has an increased range of movement, and he smiles, and there's less pain. Okay, and that is how I treat. Step 16 is minimal invasive management. So I'll run through a series of minimal invasive management, and many of us are very accomplished doctors. We can go back and investigate more or read up more about this particular management. Okay, most common equipment we use is infrared. Okay, and that's one of the managements of, again, we need to know how many sessions they have to come, what is the mechanism, how deep does it go, how many inches does it penetrate, whether it's really affecting, and there must be a stage whereby we must be able to say enough is enough, we need to try other methods because it's not healing. Again, based on the history, is it mild, moderate, or severe? Are we treating a severe disease, severe frozen shoulder with infrared? I tell you what, it's not going to heal the patient. So if we have to be thinking laterally or out of the box, we have to combine a management. It can be tense. So it's like a electrical electrodes where it will contract and let go, contracts and let go, and it also releases the pain. This is tense, TENS. We can read up about it, more about it, and it can be a ultrasound massage. Okay, and we have to go for several sessions. There is a frequency they will fix several sections, and I had experience in this. Yeah, it relieves after first or second session. Probably you have to go for 5 sessions every few days in days apart. Okay, we can also use a fresh frozen plasma and use an ultrasound guide and inject at a point of pain. We need to find out where exactly is the point of pain. Maybe it's bursitis or the tendonitis, and we have to give that spot. So some doctors are very skilled at this, and the pain relief is not immediate. It will take a few days before we realize the pain relief. So it's a gradual process. It's not immediate, unlike an ultrasound, maybe a little bit slower, but faster than a fresh frozen plasma. Okay, the other methodology would be a shockwave therapy. Okay, this is a simple equipment, and many of the clinics have it, so they do several sessions to it. Okay, it can be a shockwave therapy, and the other method will be hydrotherapy, where we use distilled water and lignocaine mixed in it, and we go through the area using the ultrasound guide, and between the head of the humerus and the muscles. So you create a gap. So they have what you call hydrotherapy. You can read up about it. Okay, some are good at Beckham or cupping. That may seems to relieve the pain. Some doctors are good at acupuncture. Acupuncture follows the pathway of endocannabinoid system. Okay, and that can relieve the pain too. I'm not familiar with this, and these are some of the methodologies followed in the clinical practice. And then we can use what you call PEMF, pulsated electromagnetic frequencies. Again, we have to go for several sessions for it to be relieved. It can be a bait itself, it can be localized, it can be this way. Okay, it's hooked on like a belt, and after a certain period, let's say 15 minutes to half an hour, it definitely tends to relieve it. Okay, this is the versions of many of the doctors practicing it. Okay, or you can use prolotherapy, where there's a rotator cuff and you can inject. There's an instant pain relief, and I may agree and disagree with this methodology. I will show you further down why all the above methods may help, may not help. Okay, step 17. Okay, and this is the most common way of treating frozen shoulder by many doctors. So we use a Kinacort or triamcinolone injection. We take 1 ml and mix it with lignocaine for instant relief. Okay, we look at the spot of most pain, and then we gradually inject it there, and there's instant pain relief. And this is the most common method most orthopedic surgeons used. And many of us It's a very easy practice, and I suggest that we can add this, okay, steroid injection on the spot. Make sure that the point of injection is the point where it's maximum pain. Okay, step 18. Okay, for every treatment, even after every treatment, we have to teach them exercises. So this is one of the points that most of us will miss, we tend to miss because we have not seen or we are not taught, because it's more of a physiotherapy, but some will have a physiotherapy attached, but doctors themselves can learn this practice. First is to stand on a side of a chair or a table, one arm resting on it, the other arm used as a pendulum. So we should increase every time when we give a steroid injection or ultrasound therapy or a PRP, we have to do this exercise to increase the range. So over the period, they will be in a better position to lift up their hand. The other method is using a towel. Use a towel backhand to increase the range of movement of the hand. So once we have to, what do you call, we have to combine two therapies. Okay, two therapies. That means a physiotherapy and a non-invasive therapy, and the recovery is very good. Okay, the other way is to like a Spider-Man. So you put two fingers against the wall and slowly climb up until your arm is up. Okay, until your arm is up. That's another way of releasing. And keep repeatedly. All these exercises repeated 10 times to 20 times over the period, slowly. That's how we increase the range of the movement. Okay, the other is pulling your hand to one side. Okay, just like you look sportsmen, they do this. Okay, and they increase the movement. The other way is stand on a table, higher table, and and slowly squat down. Put both the arms where your frozen shoulder is mostly, and slowly squat, and then get up. Slowly squat and get up. So that too will improve the range of movement. The other is use an elastic band and pull it side to side. They will also improve. Okay. Or you can use a doorknob, which is very easy. So we should repeat this 10 to 20 times a day. Over the period, the recovery is faster. Okay. Step 19. Okay. And then worst scenario, we can do arthroscopy. And this is almost invasive arthroscopy and check the shoulder per se. Okay, so if you see on the left side, that is normal. If you see on the right side, this has gone torn ligament, and this has to be surgically be corrected. You need to shave off the ruptured ligaments, and this is a procedure done under anesthesia. Okay, some of them will take omega-3, glucosamine, chondroitin, and it may help, may not help. Okay, step 20. This is my method of treating patients. This is how I look at the whole problem separately. One of the most important factors we need to see is when you look at a shoulder, the inflammation is equals to cytokines. So the growth factors may be associated with adhesions. There can be a ruptured tendon, and that can cause shortening of the fibers. There can be fibrinoid changes. And then if you look at the synovium, there can be cytokine attraction. There can be growth factor or immunological reaction. In the capsule per se, joint capsule, there can be increased collagen and increased stiffness. Okay, and if you look at the right side, there can be immunological reaction. There can be microscopic tendon fiber tear. There can be synovitis. There can be fibrosis. So how does infrared help this? I'm not very sure. How does ultrasound help this? I'm not very sure. So we need to find solutions for cytokines. Can an infrared overcome cytokines, the amount of billions of cytokines down there? Can something improve the hypertrophy of the or ruptured tendon? It's only a pain relief. If you go deeper inside, you see interleukin 17A inhibition. You see collagen 1, collagen 3, fibronectin. You can see it forms a fibrosis. Okay, all this may not be able to be corrected with the previous methodology of management as I've showed you before. Okay, and there can be, if you look at the biological markers, okay, biological studies, there can be COX-1 okay, coxygenase, COX2 in IL-6, IL-1, tumor necrotic factor. So all these factors we are doing in the frozen shoulder, and we are trying to overcome using non-steroidal anti-inflammatory. So that is why it's important to have a non-steroidal anti-inflammatory along with the physiotherapy. The improvement is very, very fast. Okay. Then if you look from a different perspective, immunobiological, you can see there's a immune cell components, inflammatory cytokines. For this reason, the past 3 slides, we go back one by one. Okay, for these, for all these inflammatory cytokines, I'm using RK0. That is the reason when we give 2 capsules to this patient, it's almost within 5 minutes on the spot, pain relief, and the patient can move. So during the patient improved movement and lack of pain, we do physiotherapy for them so that there's increased range of movement. Okay. So again, coming back, I look at history. What is the root cause? Is it local or systematic? Systemic? Is it physiotherapy added? Maybe we can give a kinocort or hydrocort injection with a zero, restore, and tribiotic. Correct the root cause step by step. After that, I'll tell the patient, probably sometimes the patient has come with multiple medications. Okay, teach them how to reduce the drugs, because on a long term, these drugs, NSAID, is going to damage the kidney. Okay, so first I will ask what's the pain score. The pain score can range from 10 to 2. So what I do, if it's mild, okay, I'll also use RK Restore because it clears out all the inflammatory. RK Restore corrects the mitochondrial dysfunction and oxidative stress secondary to cases like diabetes, having ages pathway going on. It can be inflammatory markers going on. There can be toxic metals triggering. You see, for example, cytokines triggering autoimmunity. It clears out the oxidative stress along with RK tribiotics. Okay, and it comes in 2 capsules. The first capsule is the RK Restore, second capsule is the RK Tribiotic. So if it's mild, what I do is I'll give either 2 capsules daily or 2 capsules BD. If it's moderate, I give 3 times a day, or sometimes it's 3 in the night. Why 3 in the night? So they can sleep well. When they wake up, there will not be so much of stiffness. But if it's severe, I may start 3 times a day, or 3 in the morning, 2 in the afternoon, 3 in the night, plus RK Restore, because it helps to clear out all the inflammatory markers along with oxidative stress, and tribiotics to improve their immunity. So when the pain score comes down to 3, I will slowly start reducing the NSAID first, not reduce the RK0. Okay. Once it's pain free, then we remove all the NSAID and then gradually taper the RK0 to 2 BD, and over the period of time, it will be 2 night. Okay. And after 10,000 tests in a hair test, which I've done over the past 10 years, I found the most 2 common problems associated with frozen shoulder. Okay. Number one, okay, what is the secret behind? Number one is subclinical autoimmunity. And inevitably, I have personally taken steroid injection twice by orthopedic surgeon of my left side and my right side, shoulder of pain. And then I had PRP 4 times on my right shoulder. Okay, I had PRP done on my left knee twice. I had PRP done on my neck twice. So I had fleeting joint pain. I didn't understand at that period of time it's an autoimmune condition. No wonder that when I give RK0, it improves tremendously within 5 minutes to 30 minutes. It reduces the pain so much and relaxes the patient. The other most common problem I found among most frozen shoulder is mineral deficiencies. And the number one mineral deficiency is vitamin D3. That is why we combine RK0 2 capsules, RK Restore 2 capsules, and vitamin D3 and K2. It does magic. Okay, and most people are happy and they go back and then they give it to their parents and their grandparents, their father, the mother, and you can see the zeros exploding is because it's a different phenomena. Okay, and I found two methodology in the management of frozen shoulder is better than one single management, just like infrared. It does not work. How do you address the underlying root cause? And what are the factors triggering it? Okay. And step 21. Okay. If it's very, very severe frozen shoulder, most likely we have to go for surgery, physiotherapy, correct the root cause, correct the nutrition, mineral correction, hormone correction, RK0, RK restore, RK tribiotics. Okay. These are end part. And I want to thank every doctor attending this and the frozen shoulder in a very short 30 minutes presentation. And I want to thank every doctor for attending it. Thank you. Goodbye. My name is Dr. Radha Krishna. I'm a trainer for many doctors, and I've developed products like RK0, RK Restore, RK Tribiotics, and many others. Thank you so much.